Good afternoon. On behalf of Blue Cross Blue Shield of Illinois and our parent company, Healthcare Service Corporation, I'd like to thank the National Institute for Healthcare Management for inviting us into today's discussion. Blue Cross and Blue Shield of Illinois is the largest healthcare insurance company in Illinois. We have a local presence and focus really since 1936. Our local focus helps us develop strong relationships with other organizations, which has been beneficial historically, and is even more important as healthcare evolves at a rapid pace. We know that collaboration is key. None of us can go it alone in the new world. With respect to palliative care, we aren't seeking to be experts in palliative care, but we do want to help our provider partners, who we consider to be the experts, improve access to coordinated, high-quality palliative care. We all have different roles to play in a partnership, and we found that as a payer, we could help remove the cost barriers to improve access. So now you'll hear from Dr. Carol Wilhoit about how Blue Cross and Blue Shield of Illinois and our hospital partners collaborated to improve access. Carol?
Good afternoon. In 2010, we began to focus on the problem of readmissions. Knowing that we could not address this issue in isolation, we partnered with other entities that had diverse strengths. The Illinois Hospital Association had strong relationships with hospitals. The Feinberg School of Medicine at Northwestern University had expertise and experience in care transitions and in palliative care. We had funding available for community-based activities. So collectively, we formed an entity called PREP, Preventing Readmissions Through Effective Partnerships, and through PREP have implemented a variety of programs, including some directed at palliative care. The key initiatives of PREP were to improve transitions of care, redesign hospital discharge processes, increase the focus on palliative care, strengthen hospitalist programs, and provide hospitals with standardized metrics related to readmissions. With respect to palliative care, which is really our focus today, our palliative care initiative was titled Communication and Palliative Care, or CPC for short, to emphasize the need for communication with patients about their goals of care. The CPC program aims to identify patients and implement timely communication, timely documentation and coordination, and also to enhance the delivery of patient-centered care that was consistent with the patient's own goals of care. Through the CPC programs, hospitals that were involved in the program learned key communication skills. They developed protocols to identify appropriate patients for goals of care conversations. They implemented standardized approaches for documenting patients' goals and wishes. And they collaborated with a palliative care physician mentor that was assigned to each hospital involved in the program to help them implement their program and execute a successful QI project. The CPC program was organized around several specific activities. First of all, hospitals enrolled in CPC came to Northwestern University for a 2-day interactive training with professional actors that assisted the participant teams from the hospitals in learning how to communicate with patients about their goals of care. And they learned how to have difficult conversations and became much more comfortable in actually talking to patients because they had experience in doing it through this educational program. Each hospital that participated in the program had an external physician mentor assisting the hospital in implementing their program. The physician mentor was involved in coaching, in site visits, and involving community connections, and helping interpret data, and then a whole range of activities that took place throughout the year. And then at the end of the 1-year program, the participating hospitals met for a reunion and shared their experience and were able to learn from each other. Our experience with some of the other programs of PrEP, apart from palliative care, including Project Boost, made us aware of the value of an external physician mentor to assist hospitals in developing and implementing new programs. Project Boost was recognized in 2011 with the John M. Eisenberg Patient Safety and Quality Award for their Physician Mentor Program. And this was really considered to be the secret sauce that made Project Boost effective. Therefore, based on our experience with Project Boost, based on that national recognition, we decided to include a physician mentor in many of our other programs, including the Communication and Palliative Care program. The one challenge for hospitals in implementing a program, particularly one that involves a physician mentor, is that there are costs involved in such a program. And so in order to remove the barriers to participation, BCBSIL expanded its existing hospital bonus program to cover the fees. Each hospital is still responsible for contracting with and paying the entity offering the particular program, such as the Communication and Palliative Care program, but we removed the cost barrier to make it easy for the hospital to participate. The Feinberg School of Medicine provided the clinical leadership and expertise. They provided many of the mentors and recruited other mentors as well, so that each hospital participant did have a mentor. In terms of results of the program, over the past 3 or 4 years, 29 hospitals in Illinois in 6 separate cohorts have participated and are near to completion or have completed the PrEP Communication and Palliative Care program. Through this program, there have been 127 participants who completed the program. The participants represent a range of disciplines, including physicians, nurses, social workers, and chaplains. Each hospital has implemented at least one creative program to address and implement palliative care in their own hospital and in their own communities. The feedback that we've received has been very positive, and particularly at the reunions at the end of the experience, there have been some really great stories, and I thought you might be interested in hearing some of those. At one of the reunions, a nun from one of the Catholic hospitals that participated in the program stated that she finally knows how to talk with patients about their goals of care. While she had spent her entire career working as a chaplain in the hospital setting, she really had never been comfortable with that aspect of her position. She had found this program particularly beneficial as she addressed the spiritual needs of patients. Another example is a team member from one hospital with a family physician who was also ordained as a minister. He became so engaged in the program that with the support of his hospital system, he moved from another part of the state to Chicago for a year of palliative care fellowship. He then returned to his hospital to expand the palliative care services available within the hospital and within the hospital system. On another scale, but a very concrete example, at one of the reunions, we heard about an elderly man with end-stage COPD who had been identified for the goals of care conversation because the hospital was screening people who met their target criteria for screening. He had had many hospital readmissions because of his disease. When somebody took the time to talk and understand his desires, his real goal was to sit on his deck and enjoy his backyard. Knowing that, his medical team was able to manage his care in a way that kept him at home and out of the hospital for his remaining days. And one hospital reported at the reunion that they had provided education about palliative care in their community. Deciding to choose a non-threatening setting, they participated in a community farmers market and provided education in that non-traditional setting that really got the hospital out into the community. Through this program, we've learned a number of lessons. First of all, there's a need for early senior leadership buy-in at hospitals. Certainly, physician engagement at the local level is absolutely essential for a program to succeed. We felt that even though the program we implemented had really good hands-on education up front, there was a need for better educational resources. There was certainly identified a need for coordination across sites of care within a healthcare system or community, and also better data infrastructure and quality improvement support. With that background, we're considering our next steps as we come to the end of the 4th year of this particular program. We're currently considering expanding this palliative care program for hospitals to be 3 years in length, requiring early executive sponsorship, a physician champion, very active involvement of inpatient teams, but also a team or two from local skilled nursing facilities that interact with the hospital to really expand the continuum of care over which the hospital implements its program. There's consideration of expanding the educational program to include online education, adding standardized metrics, the standardized screening tool to identify patients for goals of care conversations, increased use of POST, and as I mentioned earlier, engaging post-acute care partners. While Blue Cross Blue Shield of Illinois does not directly provide patient care, we can facilitate opportunities and reduce barriers for providers in our network so that they can improve the quality of the care that they provide.